Hello, welcome, folks. Got people joining in right now. We're so glad you're here to join us for today's webinar. Just going to give it a minute while everybody clicks in. And for those of you who are on board already, if you could let us know where you are joining us from. If you put your county or your town or your affiliation, we'd love to have you, and we'll just give it another minute or so. So if you want to grab your lunch, feel free. Okay, we've got some folks coming in. North Adams is in the house. Excellent. Franklin County Sheriff's Office. Lisa Ostafaro, good to see you. Okay, if you're just joining us, we've got more people clicking in. I invite you to let us know where you're clicking in from, your affiliation, your city, your town, making sure you're in the right webinar here. Okay. This is great. We had tremendous interest in this webinar. We had over 200 people registered, so this is really exciting to see everybody coming in. Well, welcome, Sarah, from Representative Saunders' office. AARP. Oh, this is exciting. From UMass School of Public Health. Hello, Risa. Let's see. Great Barrington. Excellent, excellent. Oh, the Girl Scouts. Awesome. This is great. Okay, thank you all. Keep letting us know who's here so you can all see to each other. Well, it's seeing from the oh, this is being shown to just the panelists, I believe. So for everybody chatting, we appreciate you letting us know who's here. Okay, unless my colleagues behind the scenes object, I'm going to get started. Okay, good afternoon, folks. My name is Andrea Freeman. I'm the policy director with the Public Health Institute of Western Massachusetts. And we're here today to really focus on rural issues, and specifically rural health issues. I want to just go over a few logistical and housekeeping items with you. Just one, this is being recorded. Just to let you know, if you'd like to see captions, you can enable that by clicking the show captions feature at the bottom of the page. We will have a question and answer period at the end of the speakers, and we ask you that instead of putting your questions in the chat, please use the Q&A feature at the bottom of your screen. That helps us be able to sort through them and see what's coming in, and it doesn't get is less likely to get lost in the chat. After this webinar, next week, we will share the recording as well as responses to questions that maybe we are not able to get to today. And then we also have we'd love your feedback at the end of the webinar today. So we'll have a link available at the end, or even if you need to click off early, it'll pop up so that you can let us know how it was. Love your feedback. And let's see, what else am I forgetting here? I just want to run through just a quick, the plan for the day here is that we will start with an overview of a recent report that the Public Health Institute of Western Mass put out in partnership with other organizations called Rural Realities, Financial Insecurity and Health Inequities in our rural communities. along with some findings from our community health needs assessments that we helped do most recently. And that'll be provided by my colleague, Lisa Rangeli. And then we've invited Senator Joe Comerford to join us to give us an overview of some state level tools and programs that share with you some of the work she is doing in the region with the entire Western Mass delegation to bring resources to the state, to the region. And then I'm really excited. We also get to hear from two regional leaders who are working in rural communities. Phoebe Walker with Franklin County Council, Franklin Council, FRCOG, Franklin Regional Council of Government, and then also Laura Kittross in Berkshire County, the Berkshire Regional Planning Association. And so then after that, we'll have some time for questions and answers. And so again, if you put your questions in the chat. And thank you all for letting us know who's in the house. And so without further delay, I'd like to bring up my colleague, Lisa Rangeli, who's going to share with us information about the report and the community health needs assessment. And Lisa is the Public Health Institute's Director of Assessment and Capacity Building, and she also oversees our Research and Evaluation Department. She's led the most recent round of regional community health needs assessments in partnership with the Western Mass Coalition of Hospitals and Insure. And she's dedicated her career to advancing social justice and racial equity by helping communities organize and use data to inform the action. And I can't think of anybody better to share with you this information. So with that, Lisa.
Thank you so much, Andrea. I'm really grateful to be part of this webinar today because this focus on our rural communities in Western Mass is so important. For the last 22 years, I've lived in both rural Hampshire and Franklin counties, so this topic is dear to my heart. I'm also excited to share highlights from two important sources of data about our rural communities because we often don't have enough data about what's going on in rural areas. I just also always start out any data conversation or presentation by saying two things. One, we're very committed to a strengths-based and asset-based approach to looking at our communities, and I know our speakers will talk to those topics. When I'm presenting data, I usually have the unenviable position of having to share the inequalities and the challenges that we see in the data. And then finally, I just like to say that when we're sharing charts and talking about percentages, it's easy to lose sight that we're talking about real people and their lived experiences. So I just always like to remind us all that we're talking about our friends, our neighbors, our family, and they're not just anonymous data points. So now we're going to look at how we define rural. There's a lot of different definitions that are floating around out there, and these are the three that the Mass State Office of Rural Health uses. And I think the middle one kind of speaks to that geographic dispersion of people, that you're in a rural area if the population is less than 10,000 people and the density is below 500 people per square mile. We also have levels of rurality that we speak about. And so level 1 is not quite as, is a little more dense than level 2. So we'll be looking at data that speaks to both. So when we talk about less rural areas, we're talking about rural level 1. And we speak about more rural areas or most rural areas, we're speaking about rural level 2. Now I'm going to look at a couple of maps that help us to understand what this means in our region. So as you can see from this map, which looks at the two tiers of rurality, we've got some of the most rural communities in the whole state are in Western Mass. Not all of them, but most of them. And we see particularly in Berkshire and Franklin counties that this is the case, which is why I'm so glad we have Phoebe and Laura here to speak about what's going on in those communities. And we know that often data does not adequately capture what's going on in communities that are rural. So again, I'm really grateful we do have some sources we can turn to. And then we have a map that shows a great innovation that's been going on at the state level in partnership with rural communities, which is to create a map that looks at rural clusters. So what are rural clusters? These are groupings of towns based on characteristics defined by the communities themselves and based on historically classified groupings of communities based on shared services, cultural commonality, or geographic cohesion in the region. So sometimes we really can't look at data at the municipal or individual town level, but because we have these clusters now, we're able to do that. So now I'm going to share data from a couple of different sources: the community health needs assessments, which are required for hospitals insurers to do every 3 years, and the community health equity survey, which the State Department of Public Health has done twice, most recently in 2023, and is planning to do it again in 2026. So these are very high level to set context for our speakers, and we hope that you will dive more deeply into each of these types of data and reports, which we will be linking to in the chat. So as you can see in this slide, when we looked across the region and collected data from a number of different communities and organizations serving those communities, we saw a lot of themes that really resonated in rural communities. We specifically were looking at certain populations, which included young children and their parents and caregivers, older adults 65 plus, immigrants and refugees, people experiencing poverty, and people who are unhoused or face housing challenges. And I'm sure it's not surprising to see these issues that came to the fore. So access to healthcare, provider shortages, lack of culturally responsive care, insurance challenges, mental health and substance use needs, just the increased demand for trauma-informed care across the board, long wait lists, and high levels of stress among caregivers of children, caregivers of older adults. No surprise that there's transportation barriers. As we know, there's limited public transit options, especially in our rural communities. Economic hardship. We know the financial stress that has only grown with the inflation that has mushroomed since the pandemic, and access to basic needs such as housing, affordability of transportation and food is really critical. And then finally, we've seen great progress with telehealth. It's really been accelerated because of the pandemic, unfortunately. But a silver lining was greater access to telehealth, but still there's lots of barriers, whether financial barriers or literacy barriers to using telehealth. So now I'm going to talk a little bit about what we found in the Rural Realities report, and then again, hopefully folks can do a deeper dive into that. So the Community Health Equity Survey was conducted from July to October 2023 and was open to all residents of the state aged 14 and plus, 14 and older. And certain communities that have experienced health inequities and are often missing from our data sources were prioritized to complete the survey. So 15,368 people across the state completed the survey. 3,037 came from rural communities. That's the data I'm going to be focusing on. And most of the respondents from the most rural communities live in Western Mass. So that's that bottom bar there, showing that we had really strong response rates from some of our most rural communities. So when we dive into the data a bit, we see that, as I mentioned from the CHNA data, access, ability to pay for basic needs is really challenging, and financial insecurity is a big challenge. So what you can see here with that bar on the left side, the gray bar, is that our most rural respondents had reported the highest challenges with paying for basic needs. And when we look at this by race and ethnicity, we see that white, non-Hispanic folks in both the less rural and most rural, a smaller percentage of them struggled to pay for basic needs than their neighbors of color. And we know that there are many structural and systemic barriers and types of discrimination that feed into these racial and ethnic differences. So we know that housing cost burden is a big challenge, and we have some maps that speak to this. So the darker the color, the greater the reporting of housing cost burden. So on the left, we have census data that shows us where the greatest housing cost burden is. And then on the right, we have those survey respondents grouped by rural cluster. And there we see that at least 1 in 5 of our most rural residents in Western Mass are reporting trouble paying for housing. So now we're going to look a little bit at the job situation for folks. So we see that the most rural respondents to the survey were more likely to report working more than one job, more than 1 in 4. And if we look at those who have no paid sick leave at work, again, we see the most rural as well as less rural are experiencing this more than our urban neighbors. We talked earlier about internet access using the CHNA data, and we also see this in the CHES survey data. And in this case, some of the less rural actually have the highest needs. So we know there's a lot of great work going on, the Alliance for Digital Equity, and the I live in Greenfield where we have municipal internet. So I'm about at the 10-minute mark and I have 2 more slides, so I'll wrap up shortly. So we see healthcare access is a huge challenge. And again, these two data sources, the CHNA and the CHES, really complement each other. And so 19%, or again, close to 1 in 5 of our most rural residents said they had unmet healthcare needs. And in Western Mass, we had a similar rate of 18%. So this rural data is for the whole state, knowing that much of the responses came from Western Mass. And then we have specifically what we saw in Western Mass. And then finally, going back to the community health needs assessment, we do see, concerning trends in depression and mental health, especially since the pandemic. So even though these data are still kind of behind, we know that there's been a rise since COVID in depression, anxiety, mental health challenges. And we spoke earlier about substance use and access to care. And we also want to just acknowledge that in our rural communities, when we think about substances, that drinking and alcohol addiction are important concerns, especially among older adults. So with that, we have a lot of great resources available on our website, on other platforms, and we'll put those in the chat, and just really excited to hear more about what's on the ground from our partners in Berkshire and Franklin County.
Lisa, thank you so much for providing all this helpful and new information. We really appreciate it. We've got links in the chat. Thank you, Kelly, for getting those in there. And we will be sharing the slides and the links following the webinar next week. So thank you so much. And now I am honored to introduce one of the hardest working people in the state legislature. I'm going to say maybe, you know what, make that the hardest working person in the Massachusetts legislature. And that's Senator Jo Comerford, who I'm really proud to have represent me. She's my state senator. She represents about 160,000 people in 25 cities that stretch from picture all the way from Northampton out to Ashburnham. Like that's near Fitchburg. That's a big stretch. And then also if you go up to Leiden, kind of in the north, all the way out to Petersham, and encompassing almost the entire Quabbin Reservoir. So it's a huge, huge region. Okay, and I think we may have just lost the senator. But I'm going to continue my introduction, but if she's not on in another second or two, we will just move forward with the program. Um, okay, so if you don't know already, Senator Comerford, she used to chair the Joint Committee on Public Health and also the Joint Committee on COVID-19, the Emergency Preparedness and Management. So she has been in this world of public health, has been a huge champion for some of the local and regional public health efforts, like just quintessential legislative champion. Um, she currently is the chair of the Joint Committee on Higher Education and vice chair of Senate Ways and Means. So we're very lucky to have her representing this region. And there she is, all the magic that comes in behind the scenes. Again, the hardest working person in the legislature. Thank you, Senator, for joining us. I will turn it without further delay. I hope you got a chance to take a deep breath. I know you're juggling lots of things today. Thank you so much for being with us.
You are very, very kind, and I'm sorry for any technical difficulties, my friends. Hi, I'm Joe, and I am actually aptly in Hyannis in a very strange hotel room where I just actually talked about rural schools. So today is all really about the well-being of our rural communities, and I'm so very grateful to the folks who organized today, and really grateful to be with this rock star panel. So I'll be quick because I know you probably have questions, and we want to get into more of a robust discussion. But first, let's zoom out. And I loved what I heard as I was on before, just about the rural indicators. I will say that these rural indicators are, and again, this is my one small perspective here for you. They're driven by budget and policy choices. So everything that we're experiencing in rural communities has everything to do with what the state, federal, and local governments decide. And so this big pot here is a pot that we visualized actually after a great prep meeting with Andrea and Jessica and others, where we were thinking, okay, so how do we really talk about rural well-being? How does health fit inside of this pot? How do we change the indicators that we're concerned about? How do we build more and greater well-being in our communities? So these are 4 of many buckets that legislators like me, not only me, all state legislators, serving Western Massachusetts care about these buckets. These are the challenges, right? So on the top left, you see inequitable formulas. I know I'm talking to people who know this better than I do because you live it. But for years, we've had inequitable Chapter 90 formula. That's our road, bridges, transportation money. Our payment in lieu of taxes, or pilot, has been wildly inequitable. We've been disadvantaged because our land values are less than Nantucket, for example. Also, our land, which is natural and working, has not been valued for what we call ecosystem services. Our school funding, which is where I'm fighting now, our Chapter 70, our rural aid, our declining enrollment schools, they've put disproportionate burden on our communities. Unrestricted government aid, or UGA, which is the sort of holy grail of a cherry sheet, which is direct spending into communities, hasn't been revisited in far too long and still flows to communities, I call them the W's out east, that don't need it, frankly. And we have other structural problems with entities like Mass Hire in terms of its funding, and we need Mass Hire in our rural communities. So that's top left. Top right is what we call a competitive disadvantage for the discretionary funds which come out in grant programs, right? So not only are some of the algorithms of formulas deriving direct state spending concerning, we in the delegation have been looking at the ways in which grant programs haven't seen us, haven't recognized who we are, haven't understood the realities in rural communities. We're also grappling, and I believe the Healy Driscoll administration is grappling with this too, a reduced municipal capacity. Our municipal up with all of the challenge, greater, wealthier communities. Then the bottom left, this is, about access. And this today is all about healthcare. We think a lot about healthcare in the legislature, about rural health in particular, and what the heck we're doing about it. But not only rural health, right? All social services and other kinds of public goods like public transportation. And then the bottom right, we're really dealing with an inequitable voice on boards and commissions and other gaps in appointments like judicial appointments, right? That leaves our communities less stable. So both our voices and our expertise and our priorities are not driving these statewide boards, and the boards and commissions that we need to function are disproportionately unfilled. Now, you may, in your big minds, big brains, think, oh, there's so many more things we should put into this vicious cycle of population decline and fiscal hardship pot, and I will be with you. But just for now, we'll leave this as the 4 things that we're paying attention to, and we'll go to the next slide. This is the same kind of slide, but really trying to show some traction. And let me just say here, and I just said this about 25 minutes ago at a rural school presentation, government can and should work in the best interest of everyone, including people in rural communities. It can and it should, but it doesn't always. And the difference between government working and not working are you. It's you on this webinar. It's entities like, the Public Health Institute of Western Mass pushing us to do better, and all the experts who you're hearing from today who are going to tell you the data, right? Data doesn't lie. And so when you're advocating, we need the data from today, and we need your own stories. And let me show you quickly what we've been able to gain. So again, let's start in the top left, forgive me. With, the challenges, as we transform these challenges, I will tell you that a full third of Chapter 90, which again is road and bridge money, is coming out now miles only. So the Chapter 90 algorithm that we've wildly shredded and criticized for years, this administration, this legislature is putting a third of it out just by miles, not by people and miles, not by economic activity, people and miles, just by miles. This works for us, where we have disproportionately lower economic activity, certainly fewer people, but boy, do we have the miles. And where we've been shortchanged and disrespected, we're starting to gain traction. Now, is it enough? No, absolutely not. And do we have years and years of deferred maintenance in our communities? You betcha. And is it so expensive to pave a mile of roads? Absolutely. But we are gaining ground. Also, the governor filed an executive order. Rep. Blay and I have a bill to reform pilot payment in lieu of taxes. And, Governor Healy said, you know what, you guys, I'm not waiting for you. And she established a pilot reform commission. And so both Rep. Blay and I have been appointed to that in our own chambers. And that is going to look at the ways in which the state-owned land, which our communities steward disproportionately, and which is part of the Commonwealth's climate goals, and which, by the way, is purifying water and feeding us, needs to be valued. And it's going to also look at the ways in which that overall formula is wildly disrespectful to Western Mass land values and Western Mass communities. So I'm psyched about this, right? Is it going to be changed tomorrow? Absolutely not. Will it be changed? Yes. Rural school aid, again, the subject of this morning for me. There's a rural schools report out that says we need to put in an additional $60 million for rural school communities. That's different than other kinds of schools that we have in Western Mass, declining enrollment funding. But we are gaining there, although I will say the progress is slow and agonizing. And that brings me to the next thing around local education funding. So we are in the legislature now through legislation passed in this current budget, participating, and all of us in our communities can participate in a local education funding commission that's happening. It's not everything in this commission, and not everything we need is being studied, but some things are that are meaningful. And we have an opportunity here to tell DESE, the Department of Elementary and Education, and Division of Local Services, what is happening in our local communities. The door is open and we are pouring through. And there was a hearing in Greenfield not too long ago, and I will tell you, our colleagues at the state were quite set back by the passion, the agony, the stories of what's happening. Similarly, the state is now undergoing a school transportation study because we know that's another ill for our communities and our students. Okay, top right. We've also seen some gains to grant programs. I'll tell you, I could tell you many stories here. Let me just tell you a concrete one. The Municipal Vulnerabilities Program, MVP, one of the big 3 grant programs, had an algorithm, a scoring algorithm that did not understand the reality in rural communities. So it was asking for things that rural communities couldn't put on the application, like intermunicipal partnerships. Now, sure, Bernardston and Leiden want to do partnerships together, but the entirety of Bernardston and Leiden are so many square miles. There are so many climate vulnerability projects inside of one of them, not on the border, where they just need to get this done, lest they don't have equitable access, for example, to emergency services. So I'm happy to say to you today that our EEA colleagues, Energy and Environment, have redone those programs scoring. Also, the MVP program now has a specific rural set-aside. Also, it's now an eco one-stop. So they've done a one-stop program where rural communities can put in an application and they'll do their best to take that application on the other side and then fund it in ways that work for rural communities without a match necessary. And that's very important, right? No match required in our eco one-stop. So right there we see real movement. And I could tell you that about many other grant programs where, for example, in housing, and here I want to really shout out Linda Dunleavy and the team at FERCOG for pushing on something called Housing Choices 2.0, which just wasn't working. It wasn't a 2.0 that worked for rural communities. And so where we need housing in order to build back our declining population, we were not getting equitable scoring for that. And then it was having a trickle effect to many other grants where you had to get the grant in order to be a Housing Choices 2.0 community. And it was wrong. So we're working there. It's all in the trenches, kind of slow work, behind the scenes work, but we're really trying to turn these programs that are your tax dollars at work into ones that come back to us. Okay, down left, we're making some changes to the kinds of money flowing to local communities. So you're going to hear a lot about the shared services work, thanks to great presentations on public health that are coming up. Let me just say that's state money that we have to continue to maintain to fund these public health excellence grants. We now have free RTAs. We have the first ever pot of money dedicated to microtransit, because in our in our huge rural communities where there are few people, maybe we can't run a big old bus, but can we run a zippy little public Uber? You betcha. Can we do door-to-door service? Absolutely. Can we feed people into direct routes? Yes. Can we get between counties? Yes. It all takes public money. We have that going on now. We also have a dirt road program. And we have funding now for passenger rail studies, housing productions, and more. And then the bottom right, I will just say, we are making some gains here. We had an aching, agonizing judicial vacancy gap. The governor heard us, and she has taken huge steps here. We also have the first ever rural representative on the Board of Elementary and Secondary Education. We had not one person from Hampshire, Franklin, or Berkshire counties on the Board of Elementary and Secondary Education, and now we do. This is not all the gains, friends, but all of these together plus more, and it's not just, of course, me, it's all of us in Western Massachusetts being urged on by you. These are making some changes. Okay, next slide. And the administration is also, the DPH and HHS friends are doing excellent work here on things like rolling out what's called the State Action for Local Public Health Excellence. So this was a grant, SAFE 2.0. it was a bill, SAFE 2.0, that we passed last session. The advocacy here, I just have to shout out Phoebe Walker, who was like the Energizer bunny engine that could for SAFE, along with many others in the public health trenches. So SAFE is passed. You're going to hear much more about how it's manifesting at the local level. But let me just say that it does four main things. And again, this, if you remember the pot before, this is all the stuff that we're trying to do to increase the services to rural communities. It sets statewide universal performance standards. So you can know whether you're in Northampton or whether you're in Leiden or whether you're in Chelsea, you have the same standards. It sends training and credentialing of our people doing this essential work. And recently, Phoebe organized a tour, a public health excellence tour that started in Orange and went to Gill and ended at UMass Amherst, where we heard about the kind of work that's happening both to establish these training and credentialing programs, but also what it really means for our largely rural public health officials to get this support. It is initiating statewide data collection, although this is moving a little slower than we might like, but the kind of visibility we'll have is really going to be real. And then it puts some state funding in the game. And this is really important. And we're going to need to hang on to this. And this is really important in terms of advocacy. This is not guaranteed at a pretty perilous time. So we're going to try to do our best. So the funding advances, we have about 160 million already in. That's helped set up the credentialing and the training and the data. That was about 40 million less than we wanted. And now we need to continue the public health excellence grants support. And Phoebe tells me that almost every rural Massachusetts town is in a shared service arrangement. This is a wild victory, a wild transformation. And we have to keep it going through our advocacy. Again, this is not guaranteed. Next slide, please. I just have, I think, two more. Okay. I'm sorry for the wrapping title. So I want you to also just get a sense of what the state legislature in partnership with the Healy Driscoll administration, and I will say again, our partners in HHS and DPH are beautiful, and there's a lot of love for rural health and rural well-being in the legislature. So we're taking some action. This is not the entirety, but it'll give you a sense of what we're thinking as we see the pretty devastating impacts of what's happening in at the federal level. So we directed $234 million to hospitals and community health centers and to the Health Safety Net Trust Fund. This is in mid-September. This was really in recognition of all the work they had done with and underinsured folks, and really trying to give them some strength before the onslaught. We also are directing more money to Mass Health. There's a great deficit there. To public health hospitals and to reproductive care. We also were just sent to the federal government or we will send it soon as the governor signs the budget, an arrangement to maximize federal reimbursements and to strengthen the contributions at the local and state level to Health Safety Net Trust Fund. We have to keep that robust, especially now. And just a quick shout out to the Healy Driscoll administration. Again, in consultation with many of you, they have submitted an application to the federal government's Rural Health Transformation Fund. And so that's looking at a number of things: population health, you can read it on the slide, innovations, training, more training, emergency response, which is significant, improving technology, and then of course, facility modernization. And the last slide here comes directly from HHS. And I think it's instructive to see how they're looking at it, right? So we envision a Commonwealth with thriving rural communities where well-being is a reality for all. And people like Eliza Lake and Kirby Lacey, Robbie Goldstein, and so many others have led this. And you can see the goals here. This is our DPH, again, in consultation with people like you, and then the outcomes that they're hoping for. And so, we see this happening now. We certainly all we all advocated with them to do this work. Again, they led it beautifully. And now we have to see what happens at the federal government and how all of this directly with regard to health, which is, of course, a part of the rural well-being, manifests for us. And, we'll need the great advocacy of the people on this call. So thank you so much. Again, sorry for any tech glitches on my part. And I'm really so grateful and moved to be with you.
Senator, thank you so much for sharing all that, helping untangle all that's going into the pot. I know sometimes we talk about it as a pie, but I like I'm glad you didn't have a picture of a pie up there because it would have made everybody hungry. So thank you for explaining all that goes into it. It's complicated. If nothing else, we all know that the devil is in the details of the algorithms, of the formula. And we're so grateful to you and your staff for tracking that and raising the issues and helping us understand it. So now I'm going to turn to two other awesome people to share with us about their work in Franklin County and in Berkshire County. I'm honored to introduce a couple folks I've had the privilege of working with for now. It's been over a decade. I can't believe it. I'm talking about Phoebe Walker and Laura Kittross, and they've got a lot in common and a lot of unique special gifts. Both Laura and Phoebe served on the Special Commission of Local and Regional Public Health. And that was a special commission that started well before COVID. They were working on this before people even really knew what public health was. They both also represent Western Mass in the statewide Coalition for Local Public Health, and they're members of the Western Mass Public Health Association. And they both have very long drives when they have to get to Boston for meetings and rallies and such. So they get huge credit for all the extra time they take getting to and from. And so let's see, Laura, some differences here. Laura's, as I said, is with the Franklin Regional Council of, I'm sorry, let's switch it. Laura, Berkshire's. She's a public health program manager at Berkshire Regional Planning Commission. They're based in Pittsfield. She oversees all sorts of projects, including the Berkshire Public Health Alliance, Berkshire Hampton Training Hub, and youth prevention and overdose prevention and harm reduction, and many more. Phoebe's the director of community health for the Franklin Regional Council of Governments, FRCOG. And again, she works on a ton of issues ranging from substance use disorder prevention and intervention, chronic disease prevention. She co-chairs the Community Benefits Committee for Bay State Franklin. She leads the CHIP for the region. We could go on and on. But what's more important about both of them is to let them share what they are doing. So Phoebe, Laura, thank you so much for being here.
Thank you.
Thank
So
you,
our job is really just to share with all of you some examples of work being done in rural counties to sort of respond to both the structural issues that Senator Comerford listed and the health data that Lisa shared. And we have been very involved as partners in Public Health Institute in thinking through what that data means. So this slide is really just kicking us off to say that people think about rural regions as, a beautiful place to visit, but it's also a place where there's a lot of hard work and collaboration going on. The pictures on the right are social connectedness work being done at a CHIP, a bus tour of a family medicine residency program to expose them to rural communities, and then a public health nurse funded through the Public Health Excellence Grant. So we're going to present together. Next slide, please. And Laura's going to kick us off.
So for some reason, I can't see the slides there, but I do have them to my left. I hope other people can see them. I don't know why they're not showing on my screen.
They're visible.
Okay, good. So as Joe mentioned, the Public Health Excellence funding is changing the map and improving equity across the state of Massachusetts. There's 54 shared service arrangements that are currently funded through the Public Health Excellence funds that have allowed the hiring of over 250 public health workers across the state. And in Franklin and Berkshire, virtually every municipality is covered by a shared service arrangement, which has really allowed us to provide professional, standardized public health services across the counties.
I think the thing I would add here is for folks on the call who may not work as closely with local public health as we do, it is transformative to actually have rural communities be able to have a professional team of public health inspectors and public health nurses. We saw in Massachusetts what happened when we didn't have public health nurses when COVID came around, and next time we'll be ready because there are now nurses covering, well, let's see, probably about 324 towns in Massachusetts. And also, I want to just point out that another thing that's not clear when we talk with our more urban partners across the state is the incredible importance of Title V and private well work. Most of the communities that I serve are either all or somewhat served only by private wells and private septic systems, and that's a burden on a local health department that larger communities don't have because they have town water and sewer. And it also makes us particularly vulnerable as rural residents to potential issues if the septic system is leaking into a private well or a private well hasn't been tested in years. So, sorry, go ahead, Laura.
I was going to say, and just to circle back to public health nursing for a minute, you know, when COVID hit, I mean, now everyone knows what contact tracing is. Public health's been doing that for about 200 years at this point. But we didn't have every municipality on the online reporting system for reportable diseases at that time. SAFE has allowed us, and this work to share services has allowed us so that next time we'll really be prepared. All the municipalities are on Maven, which is the online reporting system. We know that those diseases don't stop at the town borders, and that it's really important to have a regional way of dealing with infectious diseases. And then just to give an idea is that between the two shared services arrangements in Berkshire County this fall, we still gave close to 5,000 vaccines between the two of us, covering 31 of the 32 municipalities. Only Pittsfield does their own. And that just makes us all safer.
And one of the ways it makes us safer is on the next slide.
Yes, sorry. I thought you were going to say something else first. So again, I can't see the slides, so
Okay,
I'm assuming.
I'll go.
No, I'm
We
good. So
you're good. Okay.
Each of both Franklin and Berkshire County host a 2-county regional training hub for local public health, which means that we cover the 4 counties of Western Mass between us. We have a Berkshire Hamden training hub and then a Hampshire Franklin training hub. And what this means, and what hopefully the rest of you can see on the slide, is that every inspector throughout the state is receiving exactly the same training, which will, for the first time in Massachusetts, mean if you go into a restaurant in Pittsfield or in Provincetown, that restaurant should have been held to the same standard as the other one, and that you can be assured that, you know, in any given town, the inspectors have the same training, and that you can eat your food safely. So it's in 3 tiers: foundational knowledge, which is on their own time, an intensive classroom piece, and then an applied practice piece where they actually go out in the field with a trainer who's been trained not only in how to do an inspection, but how to pass on that knowledge appropriately to the inspector. So it's useful both to inspectors who have been doing this for 20 years and for the inspector that's been doing it for 20 days. And then there's additional workforce standards, which you can find on the DPH website around certifications and various educational requirements. The training hubs also support local public health through things like document reviews, mentoring of individuals or of health departments, what we call power hours, which are basically educational programs in subjects that are of interest or that we've been asked about. Other training needed in Berkshire County, we do a weekly mentoring call with whoever would like to join that call. And so both the hubs and the PHE grants are working towards 3 overlapping goals: increasing equity across the state, supporting shared public health services, and improving the capacity of local public health.
Want to just say one quick story about the public health training hubs. We have a wonderful trainer named Bree Dupras, who used to be the health director in East Hampton, and she just got done finishing the training for one of our newest health inspectors, who was coming fresh from having no local public health inspection experience. And when that person finished the training, they went out together, and Bree said she's doing a better food inspection than I did, as you know, with 10 years in the field. So it's really working, and it's amazing to see, after having spent decades for both of us watching some frankly pretty horrifying differences in how local public health is administered. So, and there are already 150 folks who are trained up and have made it through the food and housing, which is what's available right now. And there's 150 more in Massachusetts. So it's really going quite well. What this slide doesn't show you is that there's a parallel setup for public health nurses for the first time ever. And that's hosted at the College of Nursing at UMass Amherst. And that they've got divided the state up into 5 chunks, not 10. But those folks are developing a very similar set of ways for nurses to approach public health issues in their communities the same way and build their own competencies. So it's really an exciting time in local public health. And frankly, we couldn't have done any of it without Senator Comerford. So thank you. And next slide, please. Okay, this slide is about another kind of creative thing that's happening in a lot of rural communities. There's just been an absolute explosion of interest in Massachusetts in the international age and dementia-friendly movement. We're very fortunate to have partners with LifePath, our local aging services access point, to have a region-wide age and dementia-friendly program. That little thing up in the upper right is our 4-year plan that looks at each of the domains that are the colorful blobs you see in the bottom left and says, what can we do in Franklin County and the North Quadrant to make it better, this thing better? What are the concrete steps we can take to allow for better civic participation for older adults, for outdoor spaces that are easier for people, frankly, of any age? If you can push a walking roller, you can push a stroller on a place. So it's not just older adults who are benefiting from it, but as our communities rapidly age, we need to embrace the opportunities of that. And we also need to really think hard about how our current physical and social structures are set up and whether they're actually accessible for people. So we've been doing that work together and have been really excited by the buy-in from so many different kinds of organizations and institutions. The bottom right image is a map that is on the LifePath age-friendly page of all the little progress that has been made between the support from Mass in Motion, the Community Health and Healthy Aging Funds, Point 32 Foundation, Next 50 Foundation. We've had some amazing buy-in to the work that we're trying to do to become a place where everybody can connect. Laura, did you want to say something?
I do. Age friendly is, critically important in Berkshire County. We're not fortunate to have a great deal of funding right now around that, but we were, if not the first regional entity to join the to formally join the AARP, WHO, age-friendly communities across the country and the world. We were one of the first regional entities. It started as the age-friendly cities movement and has only over the last decade moved into looking more broadly at age-friendly communities. We are one of the oldest counties in the state, and as probably all of you know, we are not a young state to start off with, and we have had a lot of decline in our population of young adults. So not only our proportion of older adults continues to go up, and there's fewer and fewer people to take care of them. and to provide services to them. So, we hear housing and transportation are the biggest gaps. It's very difficult for people to stay in their communities, to downsize, to have different housing, to have the support that they need to stay in their housing. Access to healthcare is a problem. Right now, we're just looking at ways to incorporate age-friendly concepts into basically everything. If you're a municipality and you're doing a master plan, you're doing an open space and rec plan, you're doing any kind of planning within your municipality, think about how it's going to affect your older residents and how you can build that into the plan, because it's so important what Phoebe said earlier. If it works for those who are under 8 and it works for those who are over 80, really works for the rest of us too. There's nothing like sidewalks and benches and restrooms. That works for everyone, not just for the older adults. And then one other thing that we're working on that I'm very excited about, that we continue to try and push forward, and there's a lot of reasons why it's moved slowly, is community EMS, which is preventive work that EMS can provide in an individual's home when they're in between calls, in between emergency calls. And then mobile integrated health, which is kind of community EMS at a much larger level, where they can go in and actually provide health care as well as preventive services. And we see that as a really good answer to both age-friendly and access to healthcare. I see we're running
going to
long
run
on
out of
so
time.
should,
But
so
I do want to
move
answer
on
one
to
of the
next one.
questions that came in around social isolation and older adults, and say that that is absolutely right. It is an incredible indicator of poor health and a cause of poor health, and something that both of our regions are working on in different ways. But I know we have 4 slides left in like 5 minutes. So I think we need to give the highest possible level of our CHIP projects and move on. So next slide.
All right, so this is the Community Health Improvement Planning for Berkshire County. This is our graphic. For those who don't know, a Community Health Improvement Plan is a strategic multi-year plan that a community puts together with social service agencies and other interested stakeholders. It's a multi-year plan that guides efforts to address public health problems in a community, and it helps align what various agencies are doing. Our goals, you can see here, are very broad and ambitious, reducing mental health concerns like anxiety and depression, ensure equitable access to healthcare services, and increase opportunities and access to live a healthy lifestyle. But if you look at our objectives and strategies, we've really looked at high impact but low barrier ways to reach these goals. So instead of saying we need more mental health providers in the county and more mental health services, we've said, let's try to build social connections and decrease loneliness, exactly that question that was just asked. We know that increasing heat and increasing storms builds anxiety and it adds to it. So let's try to build resilience to climate change. When we're talking about equitable access to healthcare, yes, we have to recruit and retain new providers, but that's hard in rural areas for a lot of reasons. But can we improve that initial interaction with the front desk staff? Can we make them happier and make the patients happier? And so on. So the healthy lifestyle is a little bit more direct, and I'll let Phoebe go on to hers because we are running out of time.
Thanks. Yeah, so I won't dig in here, but just like Berkshire County, Franklin County has a community health improvement plan. This is a strength of rural communities. We play well together, and we can get folks together at tables to take a good hard look at what would make a difference over 5 years to improve health. And this is the large and overwhelming list of things that we're working on with numerous partners, including many in the room. And I just want to say that that can be really big things like digital equity, and it can be really small things like, are you a group of adults who never got your permit because you never had any family support? Then we're going to have a driver's ed and permit study group for you. So it goes from the very big systems lobbying in Boston to let's try to help you get over this barrier. And in the interest of time, I'll say next slide, please. We just have two left, which is each to tell you one one other final cool thing that's happening in rural communities. This is about the there are some really interesting models, including the work being done in Franklin County around sharing opioid abatement funds. The funds are given out in a very inequitable formula that was created at the national level that we can do nothing about, that really disadvantages rural communities in regional school districts. That said, when you buddy up together, even 15 tiny towns with just 20,000 people in their residents have been able to cobble together some money to do some great work involving supporting parents with doula care. At this point, we've already funded various levels of support for 12 adults and 13 children, including this little cutie. That's through Moms Do Care and Power, which does amazing work with parents with substance use issues. We've been working with the Recover Project to staff all recovery meetings in churches and libraries. And we've been getting Narcan boxes out absolutely everywhere and giving out mini grants to people for things like Real ID and registering your car, stuff like that when you're getting out of recovery. So small dollars going a long way there. Next slide, please.
So in Berkshire County, we've traditionally had one of the highest rates of opioid use disorders and opioid overdoses. We have a number of programs that are looking at that on the left. We also have some youth prevention programs. I'm not going to talk about any in detail, but like Phoebe, I just want to talk a little bit about sharing the opioid abatement dollars. The 8 municipalities up in North Berkshire, the northern part of the county, have joined together. And along with some determination of need money from Berkshire Health Systems related to the reopening of North Adams Regional Hospital, and with their opioid abatement funds, they've been able to, using Berkshire Regional Planning Commission as the host for it, hire a full-time coordinator to work on substance use disorder issues in North Berkshire, with some money left over for some programming, which is decided on by a community coalition. So it's been a great example of how the municipalities can come together, and then the community can come together with this Northern Berkshire Heal Coalition. The only other thing I would say is that BOPSI is kind of our overarching coalition that's countywide, that helps bring together people working in all parts of the county on these issues together on a monthly basis to talk about what we can implement to make things better. And there are websites for both BOPSI, and I believe there's also one for Spark, which I didn't have put in the chat, if you want to know more about the work of either one.
Wow. Phoebe, Laura, thank you. You can see why we wanted you to hear from Laura and Phoebe to focus on all that's going on in Franklin and Berkshire counties. This is just incredibly helpful. We are now going to open it up for questions. And we have there's one I just want to go to real quick, and then there's some for all of you. There's one, I think, one on the training map, on the training hub map, one community is in gray. Which one and why? If anybody knows the answer to that question, if not.
I do. I think it's Springfield.
Okay, so they're not
and
part.
We are helping. So they were not part of a public health excellence when we were awarded the contract for the training hub. And then when actually we pushed and other people pushed and said, look, training should not matter. You should still have standardized training regardless of whether you're part of a shared services arrangement or not. It's important for all the staff to have that training. But because it was such a large addition to our, and somebody tell me if I'm wrong, and it's not Springfield that's in gray. Yeah, I think it's the same reason, Lisa, is that they're not part of a shared service arrangement, but they are definitely we've been working with Springfield, we've been working with their inspectors, and DPH has been great about saying, it's all worked out. So but I believe it's an old map that they still have up on the website, and that's why it's in gray.
One of the most important parts of the SAFE 2.0 work has been in making sure that it applies to everyone. And people like Boston, Worcester, Springfield, they're in a different league, right? They have different needs. They need to meet the same standards. They don't need to buddy up with the other towns of 2,000 people around them. So that work is now rolling out. I don't think Springfield is on it yet, but Boston and Worcester finally are. So I think we just need to update our map, but that's why the colors are different. The assumption is not that somebody out of Laura's office would train everybody in Springfield's giant health department.
Okay, thank you. That's really helpful.
Mhm.
Okay. From a fairly easy question to I think maybe a harder question. And Senator, this might be for you, but I'll take anybody who wants to focus on it. The question is that I'm interested in how the federal cuts will affect the public health initiatives in our area and what are some potential outcomes, those cuts.
Yeah.
Anybody?
Especially
I'm happy to.
Medicaid.
Yeah, Medicaid. So, they already have affected the overall budget for fiscal year 26. So when the governor filed what is called H1, which is her first budget in this 2-year session, we have a 25-26 legislative session. She filed the fiscal year 26 budget, and she's about to file the fiscal year 27 budget. In the fiscal year 26 budget, between when she filed it in January and when we sent it to her in July for her signature, we had cut about $850 billion. Then she, on top of that, vetoed $130 million. So we were roughly at about $1 billion less. And why is that? It's not because we didn't value the programs. And many of you on this webinar, you're advocates for the programs I love too. And many programs were either held static, which means they actually got a cut because of inflation, or they were actually cut, including rural school aid, cut by $4 million. Why was that? Because already we could see the turbulence with regard to health insurance and the forthcoming cuts to Medicaid. So the Medicaid, this is the whole thing about the shutdown, friends, right? Where Democrats were trying to go back and redo the cuts to Medicaid and also redo the insurance subsidies, right? Reconsider them. Both of them will have a significant impact on Massachusetts. So we can imagine this cascading effect where folks receiving insurance subsidies, may no longer be able to afford their insurance from the exchange. Will they become eligible for Medicaid or Mass Health? Maybe, we don't know. And then will folks in Medicaid be cut? Yes, right, because of some of the redeterminations. Not the state's redetermination after COVID, but the federal. And so that will have a wild impact on our healthcare system because someone loses insurance or gets worse insurance doesn't mean they don't get sick. And you know this better than I do. And so they're going to get sick and they're going to need to go to our community health centers or practices or hospitals for care. And so the state is paying attention to that. So you'll see us, I believe, I hope, respond in the fiscal year 27 budget because we won't see all of these impacts right away. But then it's not just that, and then I'll shut up about this. It's cuts to SNAP, right? So we just had a terrible situation with SNAP, but what that obscured with 1 million people losing SNAP was with 155,000 people have already been cut from SNAP because of federal actions. Those folks don't still need food, right? They're going to need to get emergency food from state providers who will give them that emergency food, even if they don't have access to the federal SNAP benefit. And so in this and housing, all along these federal related programs, transportation, we're seeing an impact. I'll say one last thing, and that's God bless Attorney General Andrea Joy Campbell. She is doing fierce battle on federal cuts right now in the courts. And so part of what's true is that the situation's like budgeting on top of a volcano, I sometimes say, right? We see these things, and then the Attorney General and the Governor, Lieutenant Governor, have been fierce advocates, but we know there will be impacts. There have already been $1 billion worth of impacts. There will be more. And so the people on this call who care about this, you can help us by prioritizing what's most important to you. You can talk to us about increasing possible revenue. There are things, I see Phoebe's hand up, so I want to shut up, but it's a good question. We should all be tuned in on this.
I wanted to just name one particularly rural impact of federal decisions, which is the able-bodied people without dependents, which just means without very, very young dependents, requirement to work. And shout out that our CHIP project coordinator looked at the map, a DTA, of where can you volunteer if you can't work, if you can't find a job, where can you volunteer so you don't lose your SNAP benefits? And there was nothing in Franklin County. Not one place, right? So it turns out it's not that hard to become one of those places, but you have to go through a process. And we had to sort of figure out, okay, what are the right places for that to be? What would it take to get on that list? Kind of run interference between this big federal requirement that's being, that DTA can't control. And once you lose your SNAP benefits for that, you can't get them back for 2 years. Like you can't just come back on once you, I found a place to volunteer. So that's like a particular thing that if there is nowhere that is registered for you to volunteer at and you can't find a job and you meet that category, which is thousands of people in Franklin County, you lose your SNAP benefits. I mean, I just want to give an example, but otherwise I think that Joe covered it.
Well, I just want to add that people tend to think of Medicaid and food stamps. We tend to think of poverty in urban areas, but the levels are very high in our rural areas. Household incomes are actually significantly lower in rural areas. And we have a lot of friends and neighbors and colleagues who are dependent on these programs, and very high public insurance rates and very high SNAP rates. So I think this really is a rural issue. And for the reasons that Phoebe said, and also just it's harder to get to a food bank. It's harder to get to anything that you need to get to. It's harder to get to the office to renew. And now you have to renew more often. You have to recertify more often. So it's very much a rural issue.
Very much. And thank you for pointing out, again, the devil is in the details. Until look and see what are your options within a county. You got to figure out how to make it. I have another question that a participant has posted to us or shared with us about workforce development questions regarding community health workers, emergency medical technicians, EMTs, any specific strategies, and also with regards to oral dental health care, direct care for older adults, people with disabilities, any programs, any approaches to helping address these challenges? Again, with everybody further apart, it's only harder.
Some amazing work happening between the mass hires and the community colleges on trying to make a lot of that work accessible, and even in our region in the tech school at night. But I don't know, Senator, you might have a bigger 10,000 foot view of it, but
two things. One is, the state is where we've done some strong work in higher education, public higher education. So we have free community college, and now we've started to go into certificate courses. Our first certificate courses are in EMTs and paramedics because we're so worried about rural communities. However, it's not enough. So I'm learning, and in fact, thanks to FERCOG for convening a meeting with GCC and an EMT provider and a town, because we need more training inside those programs so folks can setting. So we're never done, right? So we have these free providers, but this free opportunity. I will also say that with regard to mass hire, I totally agree with Phoebe. Mass hire is doing some very strong work with the Voc Community College space. That is, we didn't talk about it, but that is another area where the algorithm is not working for Western Massachusetts. Our mass hire has the same number of people at a higher poverty rate and unemployment rate than other places in the Commonwealth, and gets significantly less. So Rep. Lay and I are convening a meeting with Maura Geary and her team because in fact the algorithm is wrong, because the algorithm relies on density of population. And we do not have that density, but we have the people, we have the miles, the poverty, and the unemployment. And so that's one of the areas where we have to push. It's one of the many undone. The undone list is long in terms of equitably getting access to this money.
Thank you. I'm gonna call it a wrap right there, unless Lisa, you got something real quick?
I just want to say data is so important to make the case. And with the 2026 Community Health Equity Survey on the horizon, we really want a robust response rate. And the higher response rate we can get in rural areas, the better, to be able to really make that data meaningful and actionable. So just please reach out to us and to our partners here if you want to be involved in helping get responses so we can let people know what the fallout is of all this change.
Lisa, quickly, what month or what season will the Community Health Equity Survey come around, just so folks know when to be looking for it?
I can't speak to the specific timeline yet, but believe
Okay.
me, we will be putting it out in our newsletters. We'll probably be doing some, other types of outreach and engagement once we know the actual timeline, but it will
Okay,
be.
so it's not happening yet. Can't help with this yet, but just giving you a heads up. Community Health Equity Survey will be coming around again. So with that, I want to thank each of you. Thank you so much for being part of this really informative, helpful focus on rural communities, on rural health. And as as the senator said earlier, the difference between government working and not working, it's you. So the more we know, how data is power, information is power, and sharing information and collaborating is what it's going to take. So thank you all and have a good weekend. Take care.